Hi, good morning. My name is Borate. I'm an assistant professor at the Oregon Health and Sciences University, and I'm here at ASCO in Chicago for ASCO 2018. I'll be discussing targeted therapy in acute myeloid leukemia at this meeting. I think the two biggest newsworthy or discussion-worthy items at this meeting in terms of targeted therapy are the IDH inhibitors and the BCL2 inhibitor venetoclax, both as single agents and in combination with azacitidine in older patients with AML. To start off with the IDH inhibitors, we have the IDH1 inhibitor ivosidenib and the IDH2 inhibitor enasidenib. We have had, there will be several abstracts presented and discussed about both inhibitors, but the IDH1 inhibitor ivosidenib was presented yesterday in the phase 1 trial in relapsed refractory AML patients. And of note, this single agent in relapsed refractory setting showed a pretty impressive complete response rate of around 35 to 40% and an overall response rate of up to 70% in these patients. The time to response was similar to an IDH2 inhibitor, was about 1.9, that is 2 months. And there were the usual complications that are to be expected with IDH inhibition, namely differentiation syndrome presenting as leukocytosis, thrombocytopenia, and some liver function abnormalities. This agent seemed to be really well tolerated, and the median overall survival in this patient population was about 18.8 months, which is not insignificant considering that this is a relapsed refractory older patient population. The IDH2 inhibitor enasidenib is already now FDA approved and available for the same patient population. The other targeted therapy in AML, which I think is significant and possibly practice-changing, is the combination of venetoclax with azacitidine. We will be discussing the data combining venetoclax at various doses with azacitidine, namely the 400 and the 800 milligram dose. The CR/CRi, or complete response rate, with this agent in an older patient population was, upwards of over 65-70%, which is again something that is clearly an improvement over azacitidine alone. It does seem that the 400 milligram dose is better tolerated, and the overall survival in this patient population has not been reached, as opposed to the 800 milligram dose, which has a fair incidence of cytopenias, febrile neutropenia, and other complications. It will be interesting to hear more data about these studies as we get more mature data for the larger phase 2 studies moving forward. There will also be discussion on a novel IDH1 inhibitor called FT2102. This is an IDH1 inhibitor similar to ivosidenib with some differences. There will be an abstract discussed by Dr. Watts looking at this agent in relapsed refractory AML. This agent also appears to be extremely promising with CR rates of over 35%. And response rates of over 50% with very tolerable complications. So in short, in summary, the targeted agent landscape for acute myeloid leukemia looks very promising, especially in our older patient population for whom it is hard to tolerate cytotoxic chemotherapy. Some of the more emerging agents that are also being discussed at this meeting that we don't have some mature data on are BET inhibitors, also known as bromodomain inhibitors, which clearly seem to have anti-leukemic effects with not tolerable toxicities. Though I think, to summarize, these would be the most promising agents that are moving forward in AML at this time. Thank you.